Carmen Heredia, Director of Access, Arizona's Medicaid system. Thank you for taking the time today to just answer some pretty important questions. It's been a while. I want to flash back to earlier this year, and I remember May 16th, I believe we got in the same elevator together for the governor's press conference announcing this big crackdown on Medicaid fraud. And you had been on the job at that time for a few months or so. Speaking on behalf of Access, after it had been defrauded for hundreds of millions of dollars already. So what has this first year been like for you?
Well, it's a big job, first of all, and it's been, for me, a time of learning the job and onboarding, but then right away at that beginning point, focusing on something that was completely unexpected. For me, it was new information walking into the job, and it's been our complete focus at the agency. We've been really consumed in this, as we should, to address it, and every division and area at Access, you know, from IT, legal, the clinical services, you know, federal relations, every division has a role. And one of the very first things I wanted to do is get everybody at the table, get everybody to pay attention and to fix this. That's what it takes. It's a whole agency approach.
Yeah, you said it consumes the office. I mean, how much time of investment is put into this specific issue of Medicaid fraud and people basically defrauding the AIHP plan? Yeah,
the AHP plan is the American Indian Health Program. And this amount of attention I don't think has ever been, you know, historically at Access. You know, fraud is investigated by the Office of Investigator General, and it was singular cases that were being addressed. As referrals came in and, you know, went through that whole process, there were maybe suspensions happening a couple times a month, if that. This is a scale that is completely unprecedented, and it is really taking every division's attention to address it. There's all aspects that need to change here.
Speaking of suspensions, in a nutshell, we've seen a lot of different allegations in the payment suspension letters to providers, and now there are more than 300 suspensions. We've seen such a variety: excessive billing, billing for the same codes repeatedly, billing for minors or those who are in jail or even dead. These letters have become very, very detailed as far as the allegations that are being found. Why is that?
Well, we want to make it very clear what it is we're seeing. We have an obligation to list out the different conduct infractions that are happening. What is the fraud that we're seeing? We are seeing also patterns and layers of bad behavior when it comes to fraud. It's not a singular one issue or billing error. It's really a sizable amount of activity that each of these providers is being you know, investigated for. It's a credible allegation of fraud, meaning that it's a preliminary step and that there's still a due process and, you know, further investigation that happens from there. But we want to be upfront and say, these are the things we're looking at. This seems like untoward behavior. We want to ask more questions.
So the investigation's already a long process. The suspensions can be appealed, and then there's another process that then takes place.
Correct, yeah. For us to get to a level of suspension, we've gone through, I've heard something like 6 layers of review through different decision-making bodies here at the agency. And that level of credible indicia of fraud is reached. We then refer that to law enforcement, and one of our law enforcement partners has to accept the referral before we place a suspension, a provider on suspension, which means freezing their Medicaid payments. We say, you know, we're not going to process claims for you anymore. You're going to go on pause while we figure the rest of this out and have those further investigations. Those 3 law enforcement partners we're partnering with are the IRS, the FBI, and the Attorney General's office, the state Attorney General. So one of those 3 accepts the referral, agrees with us that there is credible a level of fraud, and then we issue the suspension. So there are cases that are opened on their end as well, and every one of these providers is kind of on these 2 tracks. They're facing an appeal path and a process and investigation through us. And then there's, possibly a criminal side that they might be facing with the law enforcement.
Arizona Attorney General Chris Mays, when I spoke to her months ago, she told me at the time that she believed the access system needed an overhaul. Do you agree with that? And if so, what has been done to really overhaul how things are done here?
I totally agree with her. She's on point. She's been doing an amazing job at stopping this, at catching the criminality. And we've been partnering very well with her office. I do think we need an overhaul. I think what I've uncovered is a lot of things. There's policy that needs to change. There's information silos that we needed to change. There's a resource issue. I think one of the reasons that this happened at the state was a lack of resources and attention and oversight into this area. Technology is a huge part of what was missing here. Technology to catch some of the errors that you spoke about. Systems can do that. Systems can check for those things. We just had to put them in place, that access. So walking into this job, I don't want to say that I know all the answers. I think I have the benefit of hindsight, as the previous leaders did not. But I do take accountability for making sure we put the changes in place and get ourselves informed on what needs to change. We've asked for an external forensic audit to evaluate the agency so that they could tell us objectively, we're looking at this, are there other areas that we're not catching? How big is it? What else do we need to look at? And that's really informed and kind of validated our corrective actions moving forward. And we're focusing on lots of things, like I said, technology, policy, resources, how we look at the program and address disparities that led to where we are.
I'd like to know your reaction to knowing that anyone months ago could be signed up on the American Indian Health Plan you spoke of, even just by phone until recently, just knowing that that was possible before you came in and realized it.
Yeah, that's a tricky part of this, Justin. The American Indian Health Program is a fee-for-service program, meaning the claims come directly to the state. 10% of all of Access's business is fee-for-service, and that American Indian Health, just 10%. 90% of Access is managed care, which means we contract with United, Banner, Mercy Care, Molina Healthcare, a health plan, Blue Cross Blue Shield, right? That they facilitate Medicaid claiming, credentialing of providers. They establish networks. They do prior authorization for services. We contract, and they do a fantastic job, and we provide great services across the state in that model. The fee-for-service program was very skeleton, and it was here at Access. There was no managed care program, and their priority, I think, was to process claims quickly to ensure that people could quickly get into the program. There's federal law that says that the American Indian and Alaska Native community cannot be obligated to participate in managed care. And for that reason, the fee-for-service program exists and is available to them. Now, I think that it's a disparity if we don't run that program to the same level of oversight and quality that the managed care receives. That's a disparity that needs to be corrected. That needs to be reformed and changed. And it's one of the things that I'm focused on doing.
Is that going to be a long process to do something like that?
It is a long process. We have 22 tribes in Arizona. They're not all looking at the issues the same. They don't have the same resources. They don't have the same beliefs. And so to your earlier question about enrollment, this is something, just to take that example closer, we have to visit with all of them and consult with them in a meaningful way. Say, what does tribal enrollment mean to you? How do you verify tribal enrollment? It's not, I didn't know this. I didn't know that there isn't a uniform system for that. They all recognize tribal affiliation differently. So for us as the state to roll out, you get to be in this program or not, is a sensitive, very touchy subject. We want to do it right, and we need to do that in consultation with them, with their feedback. The change we made was that to make it less exploitable, the phone option was taken away. So we're making people now come in person, but we have not moved to a level of true tribal affiliation verification, which is maybe another step that we're exploring with tribes on implementing.
How soon did you realize how large the scale of fraud was when you took over?
Very early on, I saw that it was way bigger than it had looked and been, sort of studied at the surface. But I think I continue to be surprised, Justin, on how big it is. I'm still astounded with the size. I think there's new information that comes out all the time. And when we did that press conference in May, we thought this was the bulk of it, 100 providers. But then referrals from municipal, governments, from neighborhoods, from police departments just poured in with more and more and more people to investigate. And that's why the investigations have continued, and we're over 300 providers now.
Really dependent on the tips that you guys get in complaints.
Right.
Those are still coming in consistently?
They're still coming in.
Wow. How often do you meet with the Office of the Inspector General still?
We meet, I would say we definitely have a weekly standing meeting, but there are multiple other meetings in larger groups. So there's a one-on-one that I have weekly. There are at least 3 other meetings where we're meeting with larger divisions. I am working on this every single day for the majority of my day.
And I want to bring up the moratorium on provider enrollment. That's just days away from ending. December 9th, it would end. New providers can then register. Are you prepared for any sort of influx of rehab centers trying to sign back up?
Well, we've heard that they're waiting for the moratorium to lift. And so knowing that, and based on the great advice from the Attorney General's office and interviews they've done and information they have, we've actually requested CMS to allow us to extend the moratorium. We're waiting to hear what their decision is on that, but we believe that we're not ready to, lift it. I think it's been a very effective tool to combat this issue, because one of the schemes that bad actors used was to have multiple businesses. They would just transfer people, transfer assets between businesses, create layers. And it's been really difficult to get to the bottom of the issue. When we think we've addressed something, and they continue to operate, it's because funding is coming in from a different avenue, right? So the moratorium has been a really great tool to try to at least prevent new players from coming in, right? And I think we're getting to the bottom of who is in the system. Again, based on referrals, we can only get involved once we have information, or our system is now picking up, flags that are patterns of behavior that look, without getting into specific examples, anything that is concerning, we're diving into. So
that request is to CMS, that is federal, that's the Centers for Medicare Services. Medicaid Services. So was that request an extension for another 6 months or more or shorter? We did request 6 more months for the moratorium. And again, we're waiting to see from the Centers of Medicare and Medicaid Services. Okay. Now these suspended providers are licensed with the Department of Health, but are also LLCs. You had just mentioned the, different businesses that they kind of hide under these players. What if fraudsters just create more new LLCs, get licensed again with DHS at some clinic location, and then just bill access again? That's, I assume, why you'd want this extension of this moratorium. You've foreseen this type of strategy. We're taking a really hard look at our policies, Justin, on how do you get into the program? What does access enrollment look like? What is that vetting that we're doing? What policies can we put in place permanently to be able to screen who's coming in? And all of that implementation requires time, it requires feedback from the community, but we're going to make it
not just difficult, but make it a process, not an easy application where we found out people were paying business consultants and, getting online coaching and different things. Here's how you get in. Here's how you set it up with AHS. Here's how you pass site visits. All these things that we just need to not let them outsmart us.
What would be your message to the behavioral health providers that are already suspended, who've said that their services were legitimate and they think this crackdown is more of a witch hunt?
Yeah, that's a great question. I think there's a very complex part here where I'm being very conscientious of, I don't want good actors in the system, quality behavioral health providers, to have negative consequences here. They work so hard. I came from that community, Justin. I know a lot of providers in the system. We've been really focused on ensuring that we have access to care and services. So as so many providers shut down, we're constantly evaluating, are there still enough providers in network to continue services geographically, for service levels, for genders, for cultures, like for all the different ways that you have to be available. And I'm glad to say we still have a lot of availability for behavioral health residential facilities, for outpatient services. And the good actors are having to go through new hoops, and they are not necessarily happy with everything we've done because we've gone to a degree of oversight and, paperwork requirements and site audits and compliance things that they had not seen in the past. But if they have a good operation and good program, they should not have an issue. We're really focused on those actors that came in the system. If we could speak about maybe a profile of who has been, suspended. It's newer organizations that were established maybe within the last 2 years. For the large part, they did not have behavioral health experience or behavioral health historically served, that service industry. So it's individuals that are doing something kind of new for the first time that heard about this as a business opportunity and started billing the Medicaid program misinformed. So another thing we're really focused on is, what does training look like? We have training programs. Are they widely known? Are they required? How do we track that you've taken them? Make them more available, relaunch them, revamp them to make sure if you do have good intentions and you want to serve the community through providing a healthcare service, do you know how to do it? Do we know who you are? Are we vetting you out? And are you trained, and informed on how to deliver the service?
And you said you come from the behavioral health background. So I have to ask, are you aware of the fallout with maybe at least hundreds of people being displaced by the sober living homes that have been shady and shut down out of nowhere due to access funding being cut off to the facilities that would treat, quote, like patients? They seem to rarely be placed in other homes right after and they just get dumped out on the street. So what are your thoughts on this aspect of the crisis?
That's a very hard part of this. I'm not going to disagree with you. I think that some of that is happening, but we are making ourselves available. So we've put out a hotline. You've covered 211 press 7. Every individual that calls in is individually assisted. So what they need, though, is a full gamut of things. First of all, where did they come from? Did they come from out of state? Do they need transportation back to their home state? Do they need transportation back to their reservation? Do they have a home to go back to? Do they want to go home? Every person has an individual situation. There's lots of nuances. We're prioritizing making sure that treatment, sobriety, those services are available. A lot of people are declining those services. I think we're lured a lot. What we're finding is that over half of the people that are coming through our hotline are really seeking housing. So the bad actors, when they started this, they used housing as an incentive and provided housing for free many times, right? And we don't provide free housing as a Medicaid healthcare provider. That was one of the kind of wicked pieces of this situation that we're in. So if they're opting to not go into behavioral health residential treatment or outpatient services, and they do have housing, we're working with them individually on how they find housing through the housing continuum.
So this speaks to the homelessness crisis that we have going on here in the Valley, and just pretty much contributing to it. And talk about them going back to their homes or where they come from, these reservations. Are there enough resources there for them to get help? And I'm sure you're in contact with these tribal leaders.
There needs to be more, and a lot of tribal leaders are trying to stand up additional services. Part of the conversations include that. They often say we need more on our land, we need more in our own community, and there's a couple of centers that I'm going to visit later this month, actually, that are opening up. So maybe that's a positive thing, that, a silver lining is that more attention over what's missing for this community is being had, and that we're putting our heads together on addressing those needs and those gaps.
Back to the fee-for-service topic, why does a set rate rather than a fee-for-service prevent fraudulent billing in your mind?
Yeah, so I think you're speaking to the by report code. It's a technical terminology, but there are a lot of codes that are newer that then this is a national thing. They come out from CMS as by report, and that means kind of send in what your costs are and we'll pay you a percentage of what you think the rate should be. And that's very open-ended. Especially if it's not being monitored, which was part of the problem. And so one of the code changes that we implemented back in May, I think it was May 3rd, we set a rate for IOP, intensive outpatient program services. And that was because it was the code that we saw all of this, fraud, not all of the fraud, but a huge amount of the monies were going towards that code. So setting a rate was a way to, normalize what was happening. And we set that rate based on what managed care pays, and what other states pay. So it was a normal, realistic rate for that service. But I mean, we're talking about $157 something per unit when people were being reimbursed thousands of dollars for the same unit. I mean, you could see that is going to drive incentive and business towards that. Because
they were getting about 58% of what they had claimed before the set rate on that one unit alone, I believe.
They were getting 58% of what they wanted to send in as a charge, open-ended.
Wow. Then that could, like you said, could result in thousands of dollars right there alone.
Right.
Have you spoken to other directors of Medicaid agencies, just curious, across the country, maybe dealing with something similar, or is this a very isolated, fraudulent scheme here in Arizona?
Well, unfortunately, fraud in healthcare is something we're always going to be battling. Medicare and Medicaid programs, private programs are going to have compliance and program integrity. It's a constant, it's a part of the business and the vigilance that's required. I have spoken to other Medicaid directors across the country. Some states are seeing similar activity. This, I believe, started from activity that happened in another state, and folks came to Arizona from another state, and we're consulting and constantly advising states across the country as they have similar things bubbling.
But there's a uniqueness as far as many Native Americans were targeted and asked to enroll in the AIHP, and therefore the billing would begin just like that.
Right. It is a unique situation in that sense.
I'm also curious to know, on average, how long does it take for providers to get paid by Access when billing for these services as far as reimbursements go?
Right now, we're back to the average 30-day payment when they're claiming access directly. Now, again, as I mentioned, 90% of providers are billing managed care, and they have their own timeliness requirements there.
So that has nothing to do with the Access Direct payment. That's managed care
Right.
paying back out.
Yeah, and there are providers that are experiencing, I think, delays longer than those 30 days, but it has to do with, we're now asking for certain codes and services. Show us proof of the service. Before we just pay this claim, it's called prepayment review. We say, what's your clinical justification for this? Show us documentation that this is a clinical service, that you have an assessment in place, that there's medical necessity, that the service actually happened, all these things. And that takes time and review and approval. So there has been a slowness in getting some of those services out.
Have we seen any newer mutations of the Access scam develop recently?
I think that we keep learning more as investigations happen. And you could see that maybe through those conduct summaries you see that there's kind of newer layers. But this is something we're going to, I think, have a new vigilance here at the agency, a new sense of discussion. And, instead of having communication silos, we're going to comprehensively, all divisions come together to look for fraud and be ahead of it and prevent it instead of just reactive.
What are your goals for 2024?
There's so much we need to do. There is so much we have left to do. There's new technology and systems that we need to put in place. There are some additional staff we are trying to hire. We're doing a lot of community outreach and engagement. To me, it's very important that we try. I don't know that it's ever going to be possible to have trust in Medicaid, especially from tribal communities. But we have to do our part in reaching out and having those conversations. I've been spending a lot of time with tribal communities, and I hear a lot of pain and suffering. Time and time again, stories of people sharing missing loved ones and deaths that have occurred. And it's important for us to understand what's happened, listen to those stories, and then work with the healthcare providers, the tribal leaders in these communities on how we can move forward and make sure it doesn't happen again.
Do you feel like communication has to be better between other state agencies like the Department of Health Services? Obviously, you work very closely with the Attorney General's office, but you guys can only control one aspect, but DHS handles licensing and inspections. And like you said, at the end of the day, people are dying in these homes.
Yes, and I think that from, I'm new at the state, but from what I've heard from other leaders is that we've come together as state agencies over this issue in a way that historically had not happened. We're meeting several times a week with ADHS on this topic, with DES and on adult protective services, with the Department of Housing, several times a week on this topic, again, to a level that we had not done before as a state, from what I'm told.
Is there a possibility, do you think, in the long term that we ever see this sober living scheme disintegrate?
I believe there has to be an end to it because we've, again, shut down the front door. We've put in a tremendous amount of systems in place. We're on track to make 40 different system changes, and we're about halfway through that. There has to be an end to this. I think that we will always get referrals. There will always be people trying to fraud Medicaid. But this scheme in particular, it bubbled up in a specific amount of time, right? It took about 2 years for all of these players to come in. We're going to stamp it out. We are going to come to the bottom of it.